always wants what's best for me. She taught me that your health is the only true wealth. Her bigger dream, making sure everyone can lead a healthy life. Maybe you've met her too. Every day she visits communities where she is the accepted voice, and everyone respects her good sense. She sits down, never judging, just listening, challenging views, removing barriers, creating solutions, and soon enough, the whole village is thriving. No big deal. She's just creating lasting health change. When I think of it, my auntie's pretty amazing. She transforms my community, heals my country, and makes our continent blossom. Did I tell you I have a lot of aunties? They're all Amref. Wants to be like them? Join us. This is my auntie, proud and adventurous, curious and honest, energetic and a little crazy too. She's a natural caregiver, a teacher, a wise woman. I think she's 60 plus, but you never ask a woman about her age. My auntie is one of a kind. I trust her with everything, big or small. Because I know she always wants what's best for me. She taught me that your health is the only true wealth. Her bigger dream, making sure everyone can lead a healthy life. Maybe you've met her too. Every day she visits communities where she is the accepted voice, and everyone respects her good sense. She sits down, never judging, just listening, challenging views, removing barriers, creating solutions, and soon enough, the whole village is thriving. No big deal. She's just creating lasting health change. When I think of it, my auntie's pretty amazing. She transforms my community, heals my country, and makes our continent blossom. Did I tell you I have a lot of aunties? They're all Amref. Wants to be like them? Join us. This is my auntie, proud and adventurous, curious and honest, energetic and a little crazy too. She's a natural caregiver, a teacher, a wise woman. I think she's 60 plus, but you never ask a woman about her age. My auntie is one of a kind. I trust her with everything, big or small. Because I know she always wants what's best for me. She taught me that your health is the only true wealth. Her bigger dream, making sure everyone can lead a healthy life. Maybe you've met her too. Every day she visits communities where she is the accepted voice, and everyone respects her good sense. She sits down, never judging, just listening, challenging views, removing barriers, creating solutions, and soon enough, the whole village is thriving. No big deal. She's just creating lasting health change. When I think of it, my auntie's pretty amazing. She transforms my community, heals my country, and makes our continent blossom. Did I tell you I have a lot of aunties? They're all Amref. Wants to be like them? Join us. This is my auntie, proud and adventurous, curious and honest, energetic, and a little crazy too. She's a natural caregiver, a teacher, a wise woman. I think she's 60 plus, but you never ask a woman about her age. My auntie is one of a kind. I trust her with everything, big or small, because I know she always wants what's best for me. She taught me that your health is the only true wealth. Her bigger dream? Making sure everyone can lead a healthy life. Maybe you've met her too. Every day she visits communities where she is the accepted voice, and everyone respects her good sense. She sits down, never judging, just listening, challenging views, removing barriers, creating solutions, and soon enough, the whole village is thriving. No big deal. She's just creating lasting health change. When I think of it, my auntie's pretty amazing. She transforms my community, heals my country, and makes our continent blossom. Did I tell you I have a lot of aunties? They're all Amref. Wants to be like them? Join us. This is my auntie, proud and adventurous, curious and honest, energetic and a little crazy too. She's a natural caregiver, a teacher, a wise woman. I think she's 60 plus, but you never ask a woman about her age. My auntie is one of a kind. I trust her with everything, big or small, because I know she always wants what's best for me. She taught me that your health is the only true wealth. Her bigger dream? Making sure everyone can lead a healthy life. Maybe you've met her too. Every day she visits communities where she is the accepted voice, and everyone
Hello, good morning everybody. Good morning. And good morning to more than 100 people actually joining us virtually as well, wherever they may be. Good morning, good afternoon, good evening to those people joining us virtually. And here we have fairly good attendance here. People have had breakfast. So for you who are joining us virtually, I hope you've had a cup of coffee, if it's breakfast for you. Thank you for coming. My name is Dr. Githinji Gitahi. I'm the Group CEO for Amref Health Africa. I am also a commissioner for the COVID-19 Commission under President Cyril Ramaphosa. And also my boss, my Minister of Health in Kenya, is also here. So I'm also wearing that hat as well as a Kenyan in the health sector. I would like to first make some very quick hygiene announcements before we move on to the agenda. First is that to the right, towards the end, is where the washrooms are. Secondly, I would like to say that we have Wi-Fi, so please display that. Yes, that's the Wi-Fi password up there, if you want to use the password. And then we have the hashtag, World Health Assembly Fit for Purpose. So please remember those, because we'd like you to trend this particular event. I also want to start by asking whether we have any frontline health workers here with us today. If you consider yourself a frontline health worker, you can raise your hand or stand up. I don't know what's easy. We are having breakfast. Frontline health worker? Oh, there are many of them. Yes. I will inconvenience you because I want you to stand up and give a standing ovation to health workers, because this is the first time we're meeting in person for a very long time, and it's because frontline health workers have done their work, and therefore we feel safer, though we are still not in a safe world. So please stand up and let us give all health workers a very mighty clap. Thank you, thank you, thank you, thank you. Thank you very much. Thank you. Thank you very much. We have quite a packed schedule. My apologies for starting a little late, but I assure you that the content that is here is worth the patience, and we are going to finish on time. We're going to finish on time. Before I invite our speakers here, of course, we have this particular event is co-hosted between Amref Health Africa and the government of Kenya through the Ministry of Health and Seed Global Health. And the Minister of Health in Kenya is our guest of honor. We call him Dr. Mutahi Kagwe, though he's not a doctor. For the last 2 years, he's actually been the front line, and I think he's earned the title doctor by practice. We also have, I'd like to recognize the presence of the Minister of Health, Ghana. Thank you, sir, for coming. He'll be on the panel. I would like to also recognize the Minister of Health, Ethiopia, Dr. Leah Tedesse. She'll not be on panel, but she'll comment from the floor. Thank you very much, Minister, for coming. And I would like to also recognize the Undersecretary of Health from South Sudan, my friend Victoria, Dr. Victoria, who will also comment from the floor. Yes. And any other dignitaries from different delegations, Ministry of Health, if I have not mentioned your name, pardon me, but you're welcome, and we'd like to hear your views at this meeting. We know that the WHO Health Workforce agenda is also very well represented here by Jim Campbell. So Jim, thank you very much. And you're partnering with the global agenda, so thank you for being here as well. Well, according to WHO, despite the continent having 25% of the world's illness burden, the continent has only 1.3% of the world's trained health personnel. Yet, and because of that, the continent also has the most severe health personnel shortfall and is predicted to reach 6.1 million by 2030. The total anticipated global health shortfall is 14.5. The African continent contributes to 6.1 million of that. And therefore, that puts our achievement of SDGs and universal health coverage at risk. But we can't just sit and wait. As the COVID-19 pandemic has shown us, there is no civil, political, social participation and economic participation without health. We saw shutdowns of businesses, people losing jobs because of health. But at the center of the health system is the health workforce. The health workforce cannot work without its software, and that software is people, women and men who are working every day to keep people safe and to keep livelihoods ongoing. We know that that is predominantly gendered. It's predominantly women. 70% of that health workforce is women, and therefore I must also give a shout out to women who are in the front lines of the health workforce and who continue to be the backbone of the health workforce. So please give a big hand to women who practice in the health workforce. And we know, of course, that even with this big percentage of 70%, the representation at the top is different. It is very different. So today I'm wearing a badge of Women in Global Health on my lapel, and it's just to signal that we must continuously, deliberately push for more women in global health leadership, in national leadership, and therefore I'm really happy that I can say that the Undersecretary of Health from South Sudan who is here with us is a woman, the Minister of Health in South Sudan is a woman, the Minister of Health in Ethiopia who is here with us is a woman, and we have many women here who are representing women in global health leadership, not least my Cabinet Administrative Secretary, Dr. Massimo Wagangi, who will be doing the closing remarks for this meeting, and many other women leaders I see here in global health. So we must continue that agenda. But we are in a challenge, ladies and gentlemen. We are challenged because we don't have adequate health workforce, and we can't accelerate it enough in time for the next pandemic. So we also have to think about creating fit-for-purpose health workforce, re-engineering in our continent, and creating a skilled, equipped, adequately supported health workforce that is also digitally enabled and well deployed. Regionally, of course, you know the Africa Health Strategy 2016-2030 is in support of this agenda. And we know also that nations, countries, including Kenya, have taken leadership in terms of trying to ensure that the agenda of health workforce is taken forward. This is in line with the global agenda, but also with the regional agenda. And I must also mention that we have worked very closely with the Africa Union, the Africa Centers for Disease Control, and the Africa Centers for Disease Control is presented here by its current acting director, Dr. Ahmed Ogwell. Dr. Ahmed, you're here, so thank you for coming here with your team. The Africa CDC has played a really pivotal role in supporting this particular human resources agenda moving forward. Recently, the Africa Union, in its summit of heads of state in February, adopted a recommendation of the Cyril Ramaphosa Commission on COVID-19 to establish an Africa Union Health Workforce Task Team. And we are now in the modalities of establishing that, which is going to be based on changes in policy, curriculum, health financing, to ensure we can afford the health workforce we deserve and we desire. And that health task team is going to be part of our agenda moving forward. And one of the panelists, Dr. Maha, who is a commissioner of the Cyril Ramaphosa Commission, will be commenting on this as well. So, ladies and gentlemen, without much further ado, I would now like to move on to the program, and I would like to invite the Director General of Health from Kenya, Dr. Patrick Amoth, to come and take the honor of inviting the Minister, the Honorable Minister from Kenya, Honorable Senator Mutahi Kagwe, so that he can start us off this morning. So, DG Patrick Amoth, welcome.
Thank you, Dr. Gidenji, CEO of Amref Africa. Our chief guest, the Cabinet Secretary for Health for Kenya, honorable ministers present from various African countries, the Undersecretary of Health, Republic of South Sudan, distinguished guests, ladies and gentlemen, good morning. Mine is a simple task, just to be able to invite my boss, the Cabinet Secretary, to be able to make his remarks. But before I do that, let me also echo a few words regarding the importance of health workforce in delivery of healthcare services. Indeed, health workforce is perhaps the most critical plank in the delivery of healthcare services, but many a times it is its weakest link. Both the public and private sector see health workforce investment principally as a cost driver, but not as an area of investment. Yet, if you look at the total health expenditure in most of our countries, 60 to 75% of the total health expenditure is spent on the health workforce. So how do you spend 3/4 of all your resources on an investment, and then you don't see that expenditure as an investment to be able to improve the health of your people? It is also globally recognized that creating jobs for healthcare workers not only improves population health, but also spurs economic growth. The earlier speaker alluded to the fact that more than 60% of the total health workforce is women. So by promoting fit-for-purpose health workforce, we are promoting inclusion, we are reducing inequality, we are improving women empowerment, and therefore we are ensuring that we have a peaceful, prosperous planet. Cabinet Secretary, the health economy is also more resilient. We saw this during the pandemic. Probably this hotel was closed during the pandemic, but the nearest health facility to this hotel was working full blast because people needed healthcare services. So it also has the effect of stabilizing the economy during difficult times like we saw during the financial crisis of 1998 and also during the COVID-19 pandemic. So the more the reason that we need to invest more in our health workforce to spur economic growth. Also, Africa as a continent is facing a rapid epidemiological transition. We are recording more and more cases of NCDs amongst very, very young people, meaning we require to take care of them over a longer period of time. And in the long run, they are going to have all those complications attendant to NCDs. Therefore, we must have a fit-for-purpose health workforce to be able to ensure that our population remains healthy, and then we can be able to spur further economic activity. With those few remarks, Cabinet Secretary, it's my honor and pleasure to be able to invite you to address this audience. Cabinet Secretary, please.
Good morning. Hamjambo. Mko salama. That is French for those who are not from Kenya. Cabinet colleagues here present, various people from the health sector, ladies and gentlemen, I am indeed delighted to grace this very important World Health Assembly side event on fit for purpose, human resource for health in Africa. I'm equally pleased that Kenya, through the Ministry of Health, is co-hosting this event with Amref, and I recognize the important, very, very important role that Amref and my brother Gitahi's team does in our country and the wider global community in the health sector. Africa, like the rest of the world, is experiencing both demographic and epidemiological transitions coupled with inherent challenges and opportunities. Addressing population health needs and expanding equitable access to quality health services is a main foundation of the universal coverage under what in Kenya we call the Big Four agenda. The cornerstone of any dependable and working health system is its health workforce. This is critical investment that must therefore be applied efficiently to help achieve the desirable health outcomes. With the challenge of biting shortages and lack in certain skills mixes across the continent, this calls for better planning, training, recruitment, management, and development of the workforce. It is therefore imperative that the existing health workforce be fit for intended need and use. The experiences faced during COVID-19 pandemic expose the weaknesses in the global healthcare systems, including our own country, Kenya. Using the existing evidence, African countries must invest in health workforce and specialties that address their needs. Investment in primary health care is key towards attainment of universal health coverage. And in this regard, effort must be made to strengthen the health workforce at this level, including the community-level health workers and structures. The investments must include the establishment, training, continuous capacity improvement of the health workforce to ensure fit for purpose. Realizing the role played by well-oriented healthcare team leads in primary healthcare, Kenya purposely trained a pool of 50 family physicians in Cuba who are now back in Kenya and will work in the primary health networks we have established in our devolved administrative units to help upscale the universal health coverage agenda and strengthen the reverse referral. Ladies and gentlemen, Due to the rise of non-communicable diseases, including cancers, an increased antibiotic-resistant microbes and emerging and re-emerging viruses, including Ebola and other hemorrhagic fevers, COVID-19 for instance, we must assess and reevaluate the quality and quantity of the workforce. I think those two words essentially establish the discussion of the day. What is the quantity of health workforce, of health workers do we need? And secondly, what is the quality of those health workers? And perhaps a combination of the two, what is the resilience of the same in terms of future needs? Therefore, we must continue to train and retain critical health experts to take care of our population. These include infectious disease specialists, virologists, critical care specialists and teams, emergency medical teams, mRNA technologists, epidemiologists, among others. And for cancer, we need to think of super specialists, health professionals to deal with cancers of specific organs and body regions in order to have better solutions. For example, I can tell you that in Kenya, one of the critical shortages that we have is people who deal with esophagus cancer. And I don't know how many you have in the different countries, but in Kenya, I think there is only about 2-3 esophagus cancer specialists. Therefore, it means that if you get esophagus cancer, you are almost certain that that's the end. And therefore, as Africans, I believe that an African body is made in the same structure as other bodies elsewhere. It follows, therefore, that an African health specialist must be as good as any specialist anywhere on earth. And the idea that this is an African doctor and this is another doctor must get out of our system. So that's why in Kenya, we are training our health specialists, not just for Kenya, but for the global market. And we are proud that if you move around the world, that is what you will find. And therefore, in response to this global need, to this African need, to this Kenyan need, the government of Kenya hosted an international conference to explore practical solutions towards re-engineering a fit-for-purpose health workforce from the 7th to the 9th of February this year. And I'm glad to see that some friends who are in this forum were also in that forum, not least my brother from South Africa. And the forum attracted over 800 registered participants, including 100 international delegates from 24 countries, and proposed solutions to the existing challenges to ensure that we have a 21st century compliant health workforce. But this change must start from planning and then move to production. In the planning, let's plan to train health workforce also on public relations, communication skills, and other humanistic skills apart from clinical training. And this is critical. It is not just the clinical issues that we should be training our people in, it is also the non-clinical issues. And I can give several examples that prove that this is what ought to happen. And I am the Minister for Health from Kenya, so I can criticize the Ministry of Health because it is my responsibility and the buck stops with me. So when, for instance, a pregnant woman walks to deliver in one of our hospitals, and the nurses are very harsh with her, you know, when it is said in Swahili, where are you going? What do you want? When it is said in Swahili, this is a pregnant woman. I mean, it doesn't take instant mathematics to realize exactly what is happening here. So when you are cruel in a situation like that, it's a non-clinical, you might be the best doctor, you might be the best nurse, trained in the best hospitals, in the best training facilities on earth. But if you are cruel and harsh to this person, to a patient, who is already vulnerable, as it were, then you don't deserve, you don't deserve whatever status we call you, or whatever doctor or nurse or whatever we call you. You don't deserve it really, because at the end of the day, we have a motto in Kenya, and that is that our job in the Ministry of Health is to put a smile on a patient's face. That's our job, long and short of it. It doesn't matter what we do. If there is no smile on the patient's face, if there is if they don't have a good feeling, because when they came, you smiled at them, because when they came, you gave them the treatment in a humanistic manner, you treated them like human beings, you are human to them, then by the end of the day, they walk out of that hospital feeling sicker than they were prior to coming to the hospital. And really, this is a challenge, not just for the Kenyan health workforce, but for the global health workforce. I think there are many, many places where you have been as a patient. I've been as a patient in India, for example, and we do praise the workforce in India. But even there, you will hear of circumstances or situations where your cultural ethics, your cultural background is not recognized by whatever institutions you go to. And you find yourself in very embarrassing situation. You almost need to walk out of the hospital and say, God will provide. I am no longer prepared to be with man, or woman for that matter. God will provide. And when a patient feels like that, then we must ask ourselves, how did we train this health worker, both in clinical and non-clinical issues? And therefore, the final use must be in mind at the inception of the curriculum development. And we have asked ourselves, what should a health worker be trained in for the year 2030, for instance? And I'm aware of circumstances where, for example, a doctor is being trained from the first day to the last day. They have never used a computer, a laptop within the African continent. Yet we have moved on to the digital space. An operation today, a surgical operation, is going to be done concurrently with a doctor sitting in Johns Hopkins University, or Delhi, or Kigali, and you are going to be working together in that space. How is that even going to be possible? How is telemedicine going to be possible if from the inception, the workforce that we are training, does not use a computer? We have a situation, for example, in our own country, Kenya, where some of the nurses that are supposed to be traveling overseas to work have not been acclimatized to the use of technology. And therefore, we have to first train them in technology before sending them to work elsewhere. It should not be necessary. It should be part of the curriculum today. That technology must be infused so much in the system that it is a by the way. It is not a subject to discuss. At the same time, as we are talking about technology, there are other non-clinical issues also that I think are vital, for the development of a worker who will be fit to work in the year 2030. Because the people that we are training today, who are going to be in our universities, must be the people who are going to work in those years, not now. But the question is, what is that environment going to be like? And is the person we are training today going to fit in that institution? One of the weaknesses in our systems, and I don't know about other countries, but I do know, for example, that in Cuba, the Ministry of Health is also responsible for the training institutions, universities that train health workers. In Kenya, the Ministry of Health only trains nurses, but the rest of the people, the doctors and so on, are trained by other institutions that the Ministry of Health does not have any authority with. And quite frankly, little linkage with them. So what is it? What happens in those circumstances? There is a de-link. between the workforce that the universities are producing and the workforce that the Ministry of Health needs. I need esophagus cancer specialists. The University of Nairobi is giving me GPs. I need specialized nurses. For example, in oncology, the University of Nairobi is producing for me nurses who have nothing to do with oncology. And this is Kenya. We are talking about one country. So we must reinvent the structures of training so that there is a link between the institutions that train and the institutions that use. And this link is something that we are working on. I'm glad that Dr. Eva Jenga is here and Dr. Mwangangi, the team that led in the curriculum development. In that curriculum development forum that I'm speaking to, we had all the universities represented there in Mombasa so that they can begin to see the problem as it were. And it is not just a problem that is going to face us today. This is a problem that is going to face us in future because we have not begun to train the doctors of the future. The people who are here today, the doctors who are here today, are the doctors for now and maybe a few more years, hopefully, but not for long, not that long anyway. So we need to think about beyond ourselves what happens. So ladies and gentlemen, a well-trained workforce is marketable everywhere. Kenya is currently training health workforce for global market. To crown it all and to prove that our training is all-round and globally oriented and recognized, a Kenyan nurse emerged top in the first ever Ulster Guardians Global Nursing Award in Dubai out of some 24,000 applicants. And let's not forget that a Kenyan gynecologist resident was last year recognized by the World Health Organization and honored for her out-of-the-box solutions for reaching expectant women in need of services at the peak of the COVID-19 pandemic. These are but a few proud examples of where we need to take our curriculum and develop an all-round and dynamic health workforce. Ladies and gentlemen, we cannot have a complete discussion of fit-for-purpose health workforce without mentioning the role of the private sector and development partners' contribution in Africa. They have continued to be agents of change in training as well as in fusion of new methodologies. This role will, however, have to be scaled up to achieve critical coverage. As I conclude, it is my hope that this side event will help explore possible areas of cooperation amongst different actors within this field in Africa and renew the call for critically looking at opportunities for increasing investments in our health systems. In addition, we should refocus in having resilient health systems supported by fit-for-purpose health workforce from production through active service for improved population and health outcomes. My final appeal to everybody sitting in this table is through our system, through the AU, who have developed the Health Workforce Committee, and I'm glad that Ahmed is here. I think it is time for us in Africa to have a standardized system where we know that a doctor trained in Nairobi or in South Africa or in Egypt or in Addis Ababa have basically trained amongst the same standards and very high standards for that matter. A standard that we as Africans can be proud of and we as Africans can depend on. And I know that the teams that we have, our council, moves around the East African region, vetting and ensuring that training is being done at a high level. But let's scale it up. Let's scale it up. Let's not just vet ourselves as Africans and as far as our training is concerned. Let's also go to Japan. Let's also go to the US and India and elsewhere and ensure that our doctors are training at equal or better than the rest of the world doctors. we Africans need the best treatment, the best service that is available on earth. That service must be provided by a fit-for-purpose workforce trained within our continent. I thank you and wish you good deliberations. Sorry, my apologies. I got so excited about this subject because it is a pet subject of mine. I forgot to mention that I have got greetings and apologies from His Excellency President Uhuru Kenyatta, who I spoke to this morning, but in fact, he was going to be here. And he has said to me, this time I am going to sit and listen and not speak. But unfortunately, as one would expect in positions such as his, duty called, and he wasn't able to be here with us. So I cannot fit into his shoes, but since he wasn't going to speak, he was going to, as he said himself, he was going to listen. I hope that at some point, he'll also get this message. But I can assure you he is with us all the way. For those of you who are not at the conference in Mombasa, as you know, the president himself came to open that conference discussing the curriculum of, our health workforce. And therefore, I just wanted to bring his greetings. Have you accepted the greetings? Thank you very much.
Honorable Cabinet Secretary, Senator Mutahi Kagwe, thank you very much, and we do appreciate the greetings from His Excellency the President. I would now like to, before the next speaker, I would like to call up our panel to come on stage, and then we are going to hear, shortly after, we are going to hear from Dr. Kasonde Mwinga, who is the Director of Universal Health Coverage and Life Course Cluster at WHO. For now, may I ask the following to join me on stage in this order. Dr. Gossi Letlape, to just come and, as I, you follow that order, Dr. Gossi. Dr. Gossi Letlape is the President, Association of Medical Councils of Africa. So he is the boss of my boss, Dr. Eva Jenga, as far as the councils are concerned. And Dr. Jenga, another woman in global health who we respect a lot. Second, I would like to call up Professor Maha El-Rabat. Professor El-Rabat is a commissioner in the COVID-19 Commission for Africa, but also ex-Minister of Health and Population of Egypt. So Professor El-Rabat, please come up. Please assist her. Then I would like to also ask the Honorable Minister Kwaku Agyemang Manu to join me on stage. Of course, Honorable Agyemang Manu, who is known to many of you, is the Minister of Health, Ghana. And please join me, Honorable Minister. I would then like to call up Nazo Kureshi. Nazo is a Senior Community Health Systems Advisor at USAID and Head of Technical Advisory Group for Community Health Worker Return on Investment. Welcome, Nazo. And then we also have Dr. Raji Tajuddin. Dr. Raji is from the Division of Public Health Institutes and Research at Africa Centers for Disease Control and Prevention, representing here the Africa CDC and the Africa Union. Please join me up here, Dr. Raji. We do have one participant virtually. She was unable to join us in person, and that is Mrs. Dolores Wakida. Mrs. Wakida is the head of East and Central and Southern Africa College of Nurses, and we look forward to hearing her remarks as well, representing the nursing profession. Great, and they have all joined us, so the technical team will assist us to have them up there. Good, so now as we have our panelists here, isn't it a lovely panel? Please give them a hand, thank you. Thank you very much. I would now like to invite the remarks by video, virtual participation, of Dr. Kasonde as introduced. So, Dr. Kasonde, we start with you, then we go down to the panel. Thank you for joining us. Over to you.
Thank you very much, Dr. Gitahi. Distinguished guests, and with special recognition of the honorable ministers who are here present, including the Undersecretary for South Sudan and members of delegations of the World Health Assembly. Dear partners, participants, good morning. Let me start by thanking you again, Dr. Gitahi, for inviting Dr. Matsidis Omoeti, the WHO Regional Director for Africa, to speak at this event. And I'm happy to stand in for her today, as she had other urgent duties to take care of this morning. I would like to start my remarks by first acknowledging three positives for health workforce in our region and globally. The first one is how health workforce issues have become front and center of discussions globally and in our region. The second is to acknowledge the good work in countries to increase the numbers of health workers trained, despite the fact that we haven't reached the numbers we would like to reach. And the third is to acknowledge the work being done by partners with national governments to have guidelines, tools, and evidence generation that help us in improving the health workforce in the region. This World Health Assembly is an excellent opportunity for member states to discuss and adopt appropriate solutions for addressing health workforce challenges globally. And we really trust that the commitments that are made here by member states will result in accelerated, equitable access to an able and fit for purpose health workforce in Africa. And I'm really happy to have ministers of health on the panel, ministers of health in the audience from Africa, so that this work is accelerated in the region. Distinguished guests, as we continue to combat COVID-19 pandemic, we acknowledge the important roles that the health workers have effectively played to prevent, to predict, to detect, and to respond effectively to public health emergencies such as this one. This is something we should not take for granted, but something that has resulted from long-term investments in health workforce. The health workforce stock in the African region has increased from 1.8 million in 2013 to 2.8 million in 2020. This is an overall improvement by 52%. And if we adjust for population growth, the net increase is 32%. The production of health workers over the last 15 years also shows a positive trend. Health education institutions have expanded in Africa, and the estimated growing rate has been 16.2 per annum. This results in increase in numbers of trained health workers and is encouraging, though we acknowledge the need for us to do more. In terms of guidelines, tools, and standards that are generated by different partners working with governments, I would like to highlight that the World Health Organization has supported member states to conduct health labor market analysis. These analyses aim to inform advocacy and policy towards an enabled fit for purpose health workforce in countries. And these labor market analyses are a multi-sectoral powerful tool which unlocks opportunities for further investment in the health workforce. For example, based on evidence generated, Ghana, and the Minister of Health is on the panel, we understand Ghana mobilized domestic resources in 2019 to recruit about 54,000 additional health workers. In Namibia, there was an increase in budgetary allocation for health workers. In Lesotho, Lesotho increased the health workforce budgetary allocation by 15%, and this led to absorbing 27% of unemployed health workers. We urge more countries to make use of important tools and guidelines to be able to inform policy decisions in investing in health workforce. However, we also acknowledge that even though there are positive trends, there are still a lot of challenges that remain on the continent before we can be happy with an enabled and fit for purpose health workforce. In the opening remarks, Dr. Gitanji had already indicated the critical shortage of health workforce in 70% of the countries in the region. And indeed, 33 out of 47 countries that are identified globally as highly vulnerable for health workforce shortages are in the African region. In addition, there is maldistribution of healthcare workers between urban and rural areas. At the beginning of this session, Dr. Gitaji gave a shout out to the frontline health workers who were in the room. I would also like to give a shout out to different health workers that are serving our rural communities in Africa. For example, community health workers in Gemena, in the Democratic Republic of Congo, health extension workers in Ethiopia, and many other cadres that are serving rural populations. And here I would like to give a big smile to the auntie we saw in the video earlier, represented by Amref here. Distinguished guests, gender inequalities also add to the challenges, and I won't repeat the data that were already given earlier. What I would like to say is let us work together to give attention to gender responsive workforce policies so that we may increase the number of women in health leadership. Going back to the COVID-19 pandemic, this pandemic has also just exposed the acute shortage we have not just of frontline health workers, but also of emergency public health workers and critical care workers. It has exposed gaps in the ability to maintain continuity of health services while we respond to the pandemic. WHO did global surveys which confirmed that in a majority of member states, a lack of available health workers was the largest constraint to ensuring continuity of health services during the pandemic. And this has also contributed to difficulties in delivery of COVID-19 vaccines, diagnostics, and therapeutics. In East and Southern Africa, only 9 out of 18 countries trained emergency and critical care doctors during the pandemic. This is a need that needs to be addressed. An enabled fit-for-purpose health workforce will need to be agile and flexible. This workforce needs to be able to do its work in providing care during times of peace and during times of shock and stress. There is need to address care of the populations from the community at first level health facilities, at district and provincial hospitals, and through critical level care in tertiary hospitals. Distinguished guests, we also observe that regional and economic trade agreements have increased and have enabled international migration of skilled health workers. For example, too many specialized nurses in some countries have reportedly left their countries, with numbers in the last couple of years having really increased, likely accelerated by the COVID-19 demand. Ladies and gentlemen, our collective efforts are key to addressing some of these challenges that have been highlighted. And all of us who are on this forum can each contribute to solutions using our different comparative advantages. For some of us, it will be through training and ensuring that the training, as Cabinet Secretary said, Minister of Health Kenya, the standard of the training being generic in a way that people are fit for purpose, whether they are in a rural area in Africa or they are in a developed country. So some of us will focus on training. For others, it will be through creating the employment needed, through retaining the health workers. For some, it will be through regulation and other areas of managing the health workforce. As I end my remarks, I would like to, in line with the Working for Health 2022 and 2030 action plan that will be discussed at the World Health Assembly, I take this opportunity to call on all of us here to work together to do at least 3 things highlighted in this paper. One is to better optimize the use of existing health workers and create and distribute the jobs and skills needed to achieve universal health coverage. 2 is to build the diversity, availability, and capacity of the health workers and address the critical shortages that have already been highlighted. And 3, to strengthen the economic, health, and social impact of health workforce investment. Let us, each of us, do our bit. And we recognize that each of us working on our own, we can all do something. But working together towards the same goals using our different resources, we can together make strides to build a fit and for purpose workforce in Africa. Remember, health is wealth. I thank you for listening.
Something called COVID-19, which is the virus that has caused havoc globally. In our health systems in Africa, in terms of human resources, we've had a bug that has been with us for quite some time called task shifting. And as you could hear from the previous speaker, she was applauding the presence of community health workers in rural environments. But she's not crying about the lack of properly qualified professionals for those Africans that live in rural areas. The divisions are now not urban-rural, it's rich-poor. There's urban-poor, who are, in most countries are in a worse state than rural communities. And I think we need to deconstruct what task shifting means and what it has done to human resources in Africa. As the Cabinet Secretary spoke, we should look at ourselves as full human beings as Africans, not as half human beings. Task shifting was meant to be not the end, but a means to an end, a transitional mechanism whilst you train proper professionals that are fit for purpose. But in Africa, it's been seen as an end goal. That's why we applaud exploiting women as community health workers who have no prospects of improving in life and having career progression, because we want low standards for the majority of our people. And that is the Achilles heel for delivery in Africa. We create health systems that we will not use for our own healthcare. For our own healthcare, we will fly elsewhere if we don't have a private segment for the elite. And my message is that until our leaders follow the example of Fidel Castro, where you build a health system where you will go for your own healthcare needs as a head of state, then Africa will stay behind. When Fidel had cancer of the colon, his own health system managed to keep him alive for an extra 10 years. Even though they're primary healthcare focused, they still have the expertise to deal with cancers. They develop it within the system. But they also are very strong on prevention. What we have done, we have fallen for corporatization of health, where for everything we need a magic bullet. You look at COVID, everybody, there's a frenzy about vaccines. 90% of Africa is not vaccinated, and we have not disappeared, because we have resorted to simple measures of prevention. So preventative care can be corporatized because it's about personal behavior, and we do not emphasize that. Now, what we need in Africa is to look at task shifting as a transitional mechanism. We need to create fit-for-purpose health workforce that is professionalized. So when we put people into the transient means of task shifting, there has to be career progression. When we take young women into being community health workers, they can't be 60 in that position and not able to make ends meet. They should be seen as entering the health workforce, and there should be enablement of career progression to move from a community health worker to being an emergency care worker or a nurse or follow medicine. But there has to be career progression. We cannot make task shifting an end and create the turf wars that we have in our countries. We've created disasters of medical officers, whatever you call them. Now suddenly they want to be recognized as doctors. That is not a fit for purpose and professional arrangement for your human resources in health. It should not be that because you're African, you're poor in the urban environment, or you're rural and you have a brain tumor, you're going to be seen by the community health worker. But if you're like me and you, and you've imbibed expensive whiskey and you have a hangover in the urban environment, you're going to be seen by a neurosurgeon with a physician in attendance. And that is the problem with Africa, that we have internalized dehumanization. And we don't see our people as worthy. And we create systems for them that we will not use for ourselves. Either we create a public-private dichotomy, or we can get on a jet and fly to Germany for our healthcare. That is taking over the mantle of being the colonial rulers of our own people. We have become the oppressors of our own people. And health is a clear area where you see those issues. And if there's going to be fit for purpose, it has to be the cadre we create are cadres that will be entry points for every citizen in the country, including the head of state.
Well, thank you very much, Dr. Clapper, because you're bringing it. Yep, feel free to. And in fact, now, from your comments, I'm going to change my order a bit, and I'm going to go to the Honorable Minister of Ghana, because I want him to respond to this issue of creating health systems that are fit for ourselves, and also, what's happening in Ghana in terms of creating this fit-for-purpose health workforce, and feel free to respond to Dr. Letlap. And then I'll come back to Dolores, who is a nurse who is calling in, and she can also tell us what her view is about this fit-for-purpose. So, Honorable Minister, would you like to take the floor now?
Thank you very much. Yeah. More often than not, we Africans are always talking about our problems. But the positives in some of our countries are not very much mentioned. Fit for purpose health workforce. I believe Kenya and Ghana seem to have the same cultural training practices. The health training institutions are manned by the ministry to train nurses. But in our quest to expand and specialize these people, we have established a college for nursing and midwifery that trains specialists in all aspects of nursing that you can have. So we look at critical nursing, what type of nursing, what type of nursing. We have them in our country, just like Kenya might have. We are expanding our medical schools to train more doctors. We have adopted a Kenyan strategy, pushed away close to over 350 Ghanaian young people to Cuba to be trained to come back to serve our sub-district facilities, and even including some of our tertiary institutions. We have even established college for pharmacists that is also specialized in oncology pharmacy, whatever pharmacy that you can talk about. So we are on course. We have expanded such that now we have close to over 95 health training institutions that are training nurses in different cadres, community health nurses, whatever, general nurses, and so forth. And if you ask my Director General sitting there, we have a program that allows them to go on steady leave for further training, such that they don't get stuck at where we have started them. After 2 years with a certificate auxiliary nurse, you can apply for steady leave, you can move ahead to do a degree or something, diploma in some other institution. That is what we are doing. Most of our young daughters go for specialist training in our College for Physicians and Surgeons, and that is compulsory in our country. After 3 years as a young medical officer, you by all means have to go to college to specialize. Else you stay where you are, like my friend here is talking about. So all of them are running away, and the ministry and government has given them free training for specialization for all our doctors. This program started about 3 or 4 years back. We seem to have overtrained our auxiliary nurses, and we are now looking at opportunities to offload even some of them with further training. We are engaging the UK government, try to see how we can pick some of them to further train and utilize them, because like soon or late, we might not even have places for them. When you're talking about the labor market issue, it's true. The market analysis identifies factors affecting the Ghanaian health labor market dynamics, and design relevant implementation strategies to address challenges that are seriously affecting the country's health labor market. The HLMA is expected to provide evidence-based information that will be used to provide recommendations on the production of health workforce, management and tracking of inflow and outflow of health workers, and regulation of service provision through a policy change. So these are tools introduced by WHO that we are using, and that is helping us that much. We have developed our health sector staffing norms, again with tools facilitating us given by WHO, and we are moving. We are even doing digital education within our health system. All our nurses in health training institutions now write their exams remotely through the digital window, and we have started training them in that. We have started deploying a e-health system that will link all our hospitals, and that will make it mandatory for all our health workers to start using computers. What we haven't done yet, based on resources, is providing them with hands-on tools to be able to actually pick what we are supposed to do with them. We are partnering with the private facilities, especially Christian hospitals. We now have about 173,000 health workforce. About 16% of them, 19% of them are in the Christian Health Association facilities, which is semi-private sector sort of institution because they get a lot of support from government to provide care in areas where government facilities haven't been put there. Going forward, we believe that it will not take long. Ghana will begin to export nurses, not our doctors yet. And Africa will begin to take some advantage of it. In times of COVID, it's unfortunate an African country approached us, we couldn't offload. But we managed to send a few to far areas like Barbados, on bilateral friendly relationships to work there. Now we are getting a lot of applications from the Caribbeans asking for health workers from Ghana, but we are hesitating. And the collaboration between us now will give an indication of how we can also facilitate some of our people. We have even introduced French in some of our nursing training institutions, such that our neighbors in the Sahelian, who are predominantly French-speaking, may benefit from the large workforce that we are training in our country. Next 4 or 5 years to come, you will see Ghana exporting some nurses, not only to the very rich countries, but our close friends in the Sahelian region that don't seem to have adequacy. We are looking at quality, we are looking at quantities, and we believe we will get there. Thank you very much.
Fantastic. Thank you very much. In Africa, we say, I am because you are, Ubuntu. And that's what you're talking about now, Minister, that you're training so that even your neighbors, Francophone West Africa, can actually tap into your workforce. So thank you very, very much. Now, Dolores, I would like you to respond to the Minister and also to Dr. Etlape in terms of how you see the health workforce yourself. As a nurse, of course, we know the nursing profession is the backbone of health service delivery, supported by all the other cadres and supporting all the other cadres, mutual accountability and development for the health sector. Could you just use 3 minutes to respond to the previous 2 speakers? Over to you, Dolores. Hello?
Hello. Thank you very much, Dr. Gitegi.
Yes.
You cannot hear me. Oh, can you hear me now?
We can hear you now. We can hear you now and we can see you.
Thank you, Dr. Gitegi. All dignitaries present in your respective capacities, the organizers of the 75th World Health Assembly or Protocol Observes, good morning. I would like, first of all, to express my gratitude to the organizers of this side event and also to give me the opportunity to be part of the event. I look forward to sharing all the experiences. I wish to state that the shortage of the health workforce in Africa is something that has to be talked about. The health workforce is indeed the backbone of health, it has been alluded, and we know that Africa bears the highest burden of disease, yet enormous gaps remain in the number of health workers in Africa. Even a few that are there need to be highly skilled and competent. And this is where we talk about the training curriculum. The training curriculum needs to train competent health workers, both nurses and doctors, so that they can be exported elsewhere, so that they can also serve our people efficiently. As it has also been talked about the quality and the quantity of the workforce that we have. What is the quality of the workforce that we have? And it all comes from training and also from mentoring and coaching. There is also an imbalance of the health workforce. In that in African countries, health workers are mainly concentrated in the urban areas, and mainly because work conditions in the rural areas are inadequate. Medical supplies are almost not there. The working conditions are really poor. The pay is not commensurate to the services that they offer. So many of them would like to go to the urban area where they can do other things other than concentrate on their work. And therefore, the people, our people in the community are disadvantaged because of the lack of the trained health workers. The health workers need to be motivated. We have a number of talented women and men in the health sector. Our workforce is talented. Recently, we have had doctors in Uganda separating for jointed twins. So this is a commendable work that our doctors and nurses are able to do. Therefore, they need to be motivated. They must have the required equipment so that they are able to perform. They must be paid well. They must have good housing. They must have transport. They must be able to move from point A to point B within the shortest possible time. So, and the workload also needs to be looked into. The infrastructure, inadequate medical personal protective equipment. Recently, we all know how the health workforce has grappled with COVID-19. Sometimes our health workers had to get infected because of the lack of personal protectives. And this is something that the health workforce has got to do in order to be able to motivate and make a fit for purpose health workforce. It has also been mentioned about the importance of women in the health workforce. They form over 50% of the health workforce. They have a very crucial role to deliver services. As we know, women can be very, very highly motivated. And so when you motivate women, you really get a fit for purpose health workforce. And these need to be highly appreciated, recognized, and given their due respect because of the competencies that they have. We have already been told how the nurses in Kenya have been recognized, awarded because of their good performance. This is something that we need to look at. This is something that we need to be proud of, that our own are able to go and compete and be given that kind of recognition. There is also work-life imbalance for the health workers. Health workers have increased amount of physical and emotional stress, which eventually leads to job burnout. Many of our nurses, for example, and midwives really get burnout because they work long hours. They work from this shift to the other shift because they cannot leave their patients unattended. They wish to serve, but in the process, they get burnouts. And health workforce must be encouraged to take time off and prioritize their own needs in order to develop a healthy work-life balance. This is very important for a fit for purpose health workforce in Africa. Thank you.
Thank you very much, Dolores, and a big hand to Dolores Wakinda, who is joining us from Uganda, and a leader also in the health system. Now, we've had all this, and I think, from what Letlapa was saying, I couldn't actually, I'm an advocate for community health workers, okay? So don't punch me, I'm just next to you here.
It's okay, I'll just kick.
You just kick, okay, fine. So, and I want to hear from our colleague from USAID, Nozo, who actually has been involved in a study on community health workers in terms of their return on investment. And then we start to say, did this study cover also progression or not? And how do you respond to the really important question being raised here about what some of my colleagues also out there tell me, that community health worker, poor health workers for poor people. And we must get out of that mindset to that they are actually part of a holistic health system where everybody has a role, and that role is complementary across from the community health worker, community health extension worker, to the nurse, to the lab technologist, to the higher specialists. That's actually a continuum rather than to be seen as a separate cadres, but as one. So over to you. And then we'll come to Maha on this kind of Africa Union approach and systems, and also as a former minister, what do you see as the tensions that are coming up here? So over to you.
Thank you very much. Yeah. It's a real pleasure to be here to focus on this recently completed study, which was led by Exemplars in Global Health and in partnership with many institutions, including Amref Africa, that looked at the return on investment and the drivers of performance for community health workers, but as a part of multidisciplinary teams. So I think as we are thinking about rebuilding the resilient primary healthcare systems of the future, we need to also take a look at where are we now. And community health workers, we need to recognize them as a part of the health system. They need to be supported by health systems and communities. And they are responsible, and by community health workers being predominantly female women leaders in the most marginalized and underserved communities, working in teams with the primary healthcare facilities, are actually improving population health outcomes in these communities and in the most peripheral tier of the system. So no matter how the workforce is going to evolve, community health workers are going to remain important in our thinking about primary healthcare systems that are equitable, that are resilient, and that improve the reach of health systems and make them functional in the most marginalized and underserved communities. So I'm very happy to be here to both celebrate and to think about where we are and where we are going. And this particular study is very timely because it looks at the programmatic and contextual factors that are responsible for shaping a return on investment in subnational community health worker programs in routine settings. And we looked at 4 programs in 2 different countries, Kenya and Uganda. And we were looking at programs that had a reasonable level of performance. And as we collectively work together to make a case for increased investment in optimizing the community health workforce, we also need to look at how we create efficiencies in the current investments, and in the context of both the broader health workforce and as a part of primary healthcare systems. And there are 3 things that we've learned in the context of this study. One is there's a lot of variation within and across programs that we looked at. And the bottom line is that there's a significant impact that is still left on the table, and we need to optimize it. There was a 10 times difference in return on investment between the lowest performing and the highest performing program in this study. Second is that the drivers of performance in the study are highly correlated with the WHO CHW guideline recommendations on optimizing policy and system support for community health workers. The 72nd World Health Assembly was a historic one for the first ever resolution focusing on community health workers as a part of primary healthcare systems. And it noted these guidelines, which are built on evidence and subsequent recommendations. And the guidelines are built on both low evidence and moderate evidence. And I think it's great that the study has further put attention on drivers of performance that focus on supportive supervision to community health workers, essential commodities and supplies, etc. So we must double down on our commitment that began at WHA 72 and continued on when these guidelines were launched in Astana to put these recommendations into practice, particularly as a part of new commitments to strengthen the quality of existing programs. Dr. Leah is here, so Ethiopia's Health Extension Worker Optimization Program, or new policies and strategies that are really looking to integrate community health workers within the health system and as a part of the community health workforce. Kenya is another example of a country. Liberia is another one where there are new policies and strategies that are being rolled out. And we need to be vigilant about the performance, particularly at the subnational level, as these policies and strategies are implemented. Sorry. The third thing that we learned is that there are data gaps that we need to build upon. And we need to build a strong ecosystem around community health workers and enhance the quality of data at the community level through digital integration. And we are ready to engage in conversations with both countries and partners on how we use the methodology, the set of indicators, our understanding of drivers of performance in different contexts and settings, how we apply this in the broader conversations that are happening around community health workers. And lastly, I'll say that the recently launched Global Health Workforce Initiative that President Biden and the US government recently announced, we are very much focusing on community health workers as a part of multidisciplinary teams. And both in the context of supporting countries through a recommitment of that nature, or the work that we are doing since 2017 now, since we held the first Institutionalizing Community Health Conference, with country-level national priorities around community health systems, primary healthcare at the community level. Some people are more comfortable with PHC at the community level, but in supporting countries, we are hearing loud and clear that professionalization of the community health workforce and the associated financing, sustainable financing, and making a case, working on costing and investment cases is extremely important. So we are going to continue to see how we can adapt the framework, the findings, and the study in our dialogue with countries through a variety of initiatives and work that we have been doing with countries. And I'd like to, once again, in closing, sitting alongside distinguished leaders from Ghana, Ethiopia, South Sudan, Kenya, and other countries that are present, we are very much inspired by your rethinking around the positioning of community health workers and new policies and strategies, both as a part of these multidisciplinary workforce teams, but also as a part of revitalizing your primary healthcare system to make progress towards universal health coverage. We're inspired by your new policies and strategies and commitments, and we look forward to our ongoing work with you. Thank you.
Thank you. Thank you very, very much. And I'm hearing alignment here. It's about professionalization, actually. And I'm hearing that this study is saying there is variability. That variability is not good for the health system. If you can't then invest, then why have the cadre if you can't invest in it? So that it's actually professional and being a part of the multidisciplinary team in a professionalized and regulated manner. So, Professor Maha, would you like to comment on this tension and also how you can engage more stakeholders from the professional associations of doctors, nurses, creating multidisciplinary teams, your experience as a Minister of Health in Egypt, and also maybe comment on the Africa Health Workforce Task Team. And then we'll ask Taj to conclude in terms of what's the position of the Africa Union and Africa CDC on this agenda. Over to you, Professor.
Well, thank you. Is it working? Yes. Well, thank you very much. You know, hearing and listening to the different views, to the different articulation of the views and the oversight of what is really needed for Africa and for the health workforce is really very intriguing, because at the very end you're going to find, or we find, that we have bits and pieces of things that do not really fit into the overall framework that we're really looking for. It's a fit for purpose workforce, with all of the cadre, with all of the professionals, with all of the skills, with all of the training, but it's the oversight of what do we really want and how do we want our health system to function for the outcomes that they are built for. taking into consideration the different views of the different stakeholders at stake. So we're talking now about the community health workers, and definitely the community health workers are part of the system, however it is formulated or organized or structures. What we're looking for now is to the renewal or the restructuring of our health systems in a way where the health workforce is at the heart or the center of its restructuring that would support its resilience. So we're talking about cadres, different cadres, not only physicians, not nurses, not only community health workers, but it's the functioning, how they should function in a system which really supports the numbers, the quality, the training, the mix, the skill mix, and in a way flexible enough to support the resilience of the health system. This is how I look at it from the very higher overview. Each cadre is really very important in the health workforce. So we cannot give advantage of one of the cadres towards the other. They are all the health workforce team that should support the functioning of the services, should be people-centered, should be. So the investment or the business model should really capture all of those views in a way that really supports the investment and the real investment that takes into consideration shorter term needs, medium term, and a longer term investment. As we're talking, this is a future literacy. What is happening now might be different than what is going to happen because of transitions that we are seeing in epidemiological transition, in the technology, the digital transitions, everything. So there are opportunities, but still there are challenges that has to be faced or framed within the framework for the restructuring of the fit-for-purpose health workforce. So it's the purpose that we really have to identify. We have to have the oversight for this purpose for all of the cadres that we are developing. So it's quantity, quality, it's and we can see things that came out from the Kenya conference about the training, about the curricula, about the primary health care, about so many things. And we have opportunities that are there, the digitalization, the evidence generation, even the collaboration between countries, between international organizations. So how to bring this into a framework of action that really supports the restructuring or the renewal. I like to say it's a renewal because we're not inventing a new vision, but we are renewing our oversight and vision in order to really support the restructuring or re-engineering of a health workforce that is really fit for the purpose with the identified purpose that we are restructuring them for. So this is like a complete comprehensive framework. I see it. I'm very much, Your Excellency, with the community health workers. And I know that they can do miracles, not only in poorer, and I hate to say poor and rich. I hate this differentiation or dichotomy, not only in the less privileged areas, but in many areas where they are really supporting a particular cause or a particular job description that they are doing, but the difference could be seen, and the difference is really evident in many of the environments where they work and how they are doing it. The most important thing is to put them into the right framework for the system where they are really serving. So I am with the community, and I'm with the whole cadre or the whole workforce. So it's nurses, physicians, technicians, community health workers, whoever is there, the pharmacy people. So they're all together into this action. I only want to come through now to the AU Commission and how it's really planning for this health, fit-for-purpose health workforce. So the AU Commission has secured the mandate to establish the African Union Health Workforce Task Team. And this is like the basis for this development or restructuring, and to support the implementation of Africa's CDC framework for action for the health workforce development. And this is done, or should be done, established and implemented through the social compact of the health workforce. And the compact for the team, which is the framework of action actually. The health workforce team is there to set the targets, set the goals, the targets, the resources, the needs, the tools that are needed, and as well to see like the peer reviews or the peer support to countries, but with support and with the commitment of the member states to this compact and its framework of action. So all of this, they will require so many, the establishment of partnerships with stakeholders. So we name the stakeholders, and I always say, and sometimes not so many agree with me, I would bring all stakeholders on board, because this is a very, it's a very broad and a very directed strategy that we need to bring stakeholders. So we have the networks, we have the institutions, the academics, the international agencies. We need to support what is there, because we need, this is a multidimensional, multi-sectorial initiative that will support and will need the support of all agencies, stakeholders that should come together into a regulated partnership. The public, the private, the agencies, the institutions, academic institutions, because each and every one of this partnership will require a particular strategy for implementation and for strengthening this partnership to support the framework of action for the health workforce development. So I would say, I would bring in, because if we're talking about this, we need to have the strategy. We need to have policies that would support the retention of the health workforce, the succession plans of the health workforce. So the policies, the regulations, the governance structure is really very important as it supports the forward movement of the health workforce strategy development. So thank you very much.
Thank you very, very much. And please, a big hand for Samaha. These flash discs are on the table. You feel free to carry them. They have a lot of the information that's been discussed. Now, as we come to the end of this session, I'm going to ask you to give us just 10 minutes, because I would like to, before Taj speaks, we have 2 member states here that I would like to address the Africa CDC in terms of what kind of support do we need for those countries under the Africa CDC, Africa Union, under this task team, and the compacts that are going to happen between Africa CDC and the countries. What are the country demands? If I could request Minister Leah Tedese, in 2 minutes, what would you say would be the country demands to this task team and the Africa CDC? And also, I'll come to Dr. Victoria as well. So, Dr. Tedese.
Thank you very much. Thank you, Gitinji, for this opportunity, and I really appreciate the government of Kenya and Amref for organizing this event. And thank you all panelists. The asks may be many, and a lot has been said in this discussion on the key pillar of health workforce. And I think one issue that was also raised by Honorable Mutahi was the role of the Ministry of Health in terms of the health workforce training in our countries. As was mentioned, it's really diverse. And for example, for us as Ministry of Health, we don't have a formal authority, as was mentioned by Honorable Mutahi, on the training, but we do engage with the Ministry of Education in terms of ensuring the curriculum is harmonized. We have so many different schools who had their own different curriculum, even within country, let alone what was mentioned as a continent. But we are working towards harmonizing and ensuring we have the competencies we need as Ministry of Health for those workforce that are being produced by the Education Ministry. But how do we really ensure that this is really formalized, and not just in the training, but it's the whole continuum, but the training is a key component that I think the task team need to help on. What are the critical issues need to be addressed in our curriculum, particularly from the learning we have from the pandemic. And that includes even the non-clinical ones that was mentioned earlier on the compassionate care and the technology that were mentioned, but also on the critical competencies that are needed in the training. But it also needs to be a guidance that's needed on what are the key workforce that we also regularly need to review and increase. because we have to train from the community health workers up to the different specialties. As was mentioned, we need all the cadre, but every time I think we need to review and see what are the critical workforce that are not yet, that are very few and need to be increased, particularly as we are in this new public health order, like the emergency technicians and field epidemiologists and others. But also, what are the critical competencies needed for all workforce in times of such emergencies? We know we are immensely grateful of how our health workforce responded, but we know how difficult it was for all of them to really quickly respond and give the needed care because of all the uncertainties, and they were not well equipped for those kinds of emergencies. So really this critical aspect of the training, and how can we make it a uniform one in terms of the different nations. And the other one is on the community health workforce. I want to also emphasize on really making sure that formally paid and formally trained workers, they need to pass through formal training, and they need to be in the regular payrolls across the nation. And that's one of the reasons for us as Ethiopia, our community health worker extension program was consistent and sustained, bringing different improvements, but also, as was mentioned earlier, we are now doing a new roadmap of how to strengthen it, because the health workers not only need the training, but the linkage with other health workers to deliver the needed services at the primary healthcare level. So how do we make sure that synergy is created by the whole continuum of the primary healthcare, by the community health workers up to the different levels of care in the primary healthcare continuum, to make them really efficient in the work they do in the community. So I think those are the areas that are very critical for our way forward. And also, last but not least, is the gender issue we need to always not forget. Thank you very much.
Thank you. Thank you very, very much. So, Taj, you've heard there are member state demands, I would say, that we need to put in consideration. I would like to hear from Dr. Victoria from South Sudan, Under Secretary of Health. Over to you.
Thank you so much for the opportunity. Let me recognize the presence of all the dignitaries and thank Government of Kenya for organizing this important event, and also thank the panelists for the insightful and resourceful discussion they've had. South Sudan, of course, as all of you know, has a special, different context given the complexity and the conflict. And as we heard yesterday, there's no health without peace and no peace without health. However, we are counting on the opportunity of the current peace agreement to make sure that we are heading towards and catching up with our sister states. Our challenges are not different from the other countries. Human resource for health remains a big gap, though we have strived over the years to invest in training health cadre with support from countries like Kenya, Tanzania, Ethiopia. And I want to give special thanks to the government of Ethiopia. For the last few years, they've trained more than 90 specialists in South Sudan in different specialties, mainly the basic specialization of Afsangani surgery in different universities in Ethiopia, and they continue to support. Recently, they have also an intake of 29 specialists from different specialties, but again, we still have a gap in subspecialization. Community health workers, the Ministry of Health has launched Boma Health Initiative in 2017, similar to extension care workers of Ethiopia and others. And they continue to provide referral and early detection at the primary healthcare level. And I feel that they're quite important and part of parcel of the health system, especially in countries like ours, where issues of road network and insecurity and reaching communities out of reach remains a challenge. However, I do agree with Professor Etlape that it's not going to be a permanent solution. In the long run, task shifting and task sharing might be phased out, but we currently, in countries like our context, we still need them, and we still count on Africa CDC and the task team to provide best practices and keep looking into innovative approaches of improving this kind of initiatives for the benefit of the healthcare system. In terms of COVID-19, of course, COVID-19 have exposed a lot of challenges within the healthcare system, be it from human resource or infrastructure, and it has to some other places become a blessing in disguise, and we're able to equip our facilities and the lab and the diagnostics, and perhaps it also showed that lack of field epidemiology was a gap. But with support from US CDC, we currently launched the AFINET field epidemiology training. We've graduated one cohort, and one cohort is currently running. We believe that epidemic preparedness and response is very important and very critical as we continue to have emerging epidemics. And again, Africa CDC, this is where we want the support in terms of technical assistance and resourcing, public health institutes of our countries to make sure that we are meeting the demand and we are able to respond to such epidemics and emerging epidemics. Like currently, we're also hearing about the new monkeypox and other things coming up. So it's important to continue having the engagement and the guidance and the policy direction on how to handle these kind of things. So basically, these are a few things I wanted to share, but it's very important to have a fit-for-purpose healthcare workforce in Africa, and I think working together, collaborating is important. We have recently trained a number of health nurses and doctors in emergency care with support from Egypt, government of Egypt. Yeah. We have a number of doctors in the Egyptian fellowship. So these kind of initiatives and collaborations are important, and I think working together and sharing experiences and best practices will help us move forward. The most important thing is health financing. And without meeting the Abuja declaration of 15%, I quote His Excellency Uhuru Kenyatta yesterday in his remarks. The 15% Abuja declaration is important. Mobilizing domestic resources and owning health programs is important. Our government need to commit to the 15% Abuja declaration. They need to mobilize domestic resources and retention packages for healthcare workers, because there's a lot of brain drain within the country to NGOs and outside the country to neighboring countries. As now we have a number of doctors trained in Kenya, but they remain in Kenya, registered there, because of the common market agreement, and they're not able to come back to South Sudan. So unless we have really approaches of having a good retention package, supporting doctors and healthcare workers to work in remote areas, we'll not be able to move forward. Lastly, I want to thank Amref for supporting South Sudan in healthcare cadre, especially mid-level cadre. We have been able to train more than 1,000 professional midwives because of Amref, and they continue to support young girls to enter into training of nurse and midwifery. And a new trend is joining of male midwives, which was not known in the past. Now we have a number of male midwives as well joining the profession, and that was with support from Amref. But again, health financing is one big area that we need the support from Amref and Africa CDC and the task force to help the country win. Thank you.
Thank you very, very much. I know we are running out of time, so unless there is another government delegation that really wants to make a remark, but I will get back here. But I also want to reflect on and thank UNFPA that has actually been supporting a lot of the training for health workers that we are doing in South Sudan, which we would not have been able to do it without the support of UNFPA and other partners. So thank you very much. So, Taj, you heard from the minister from Ghana, you've heard from Ethiopia, you've heard from South Sudan, and you've heard from the panelists. So, what is in plan from Africa CDC?
No, thank you so much, Gitinji. Let me also join other colleagues to thank the government of Kenya, Amref, and SEED Global Health for putting this together, very timely and critical. So if there is anything we've learned from the COVID-19 pandemic, I think is the importance of scaling up and expanding workforce development on the continent of Africa. Now, we need to divide what is it that is expected from member states and what is it that is expected from Africa CDC being a continental institution. We know that our member states are not at the same level in terms of development. But I think first and foremost, each and every member state need to really define what exactly is needed as far as workforce or health workforce is concerned. Look at what we are seeing from the COVID-19 pandemic and what is needed to build back better and stronger. Number two, investment, in health workforce is critical at this junction. The PAMSEC from South Sudan has mentioned that. We have maybe 3 or 4 member states, who have actually heeded the Abuja call for 15% GDP to go into health. And with that investment, there is no way we can scale up, workforce development. Number 3, coordination, at the level of our member state. We have so many partners doing one thing or the other as far as the workforce development agenda is concerned in our member states. Some are duplicating efforts, a lot of parallel programs. So we expect member states to also take that necessary leadership, to bring everybody around the table in the name of one country, one plan, to ensure that there is appropriate streamlining of what is needed based on what has been defined. Number 4, we expect our member state, in terms of job placement, in terms of incentivizing the health workers, because without adequate incentive, nobody will stay in the rural areas. Then 3, still within the context of job placement, incentivizing, but also career development. I remember as a young resident doctor back home in Nigeria, once you're a senior registrar, you have 1 year placement abroad, so that in itself is an incentive. Today, we no longer have that, so how do you compete? How do you, get the sort of training people from the global north are getting? So some of these things is very, very critical for us to be able to retain those people that we are training as a continent. So let's shift here and go to Africa CDC. I heard a request from Minister Leah. Now, so we expect as Africa CDC to actually take the leadership, and we have done that. Since Africa CDC came on board, we have always advocated, for the need to invest in workforce development. In fact, when you look at our first 5-year strategic plan, workforce development is a cross-cutting enabler, whether surveillance, whether disease intelligence, whether lab, whether health informatics, and so on and so forth. And with the COVID-19 pandemic, the head of state and government, in their wisdom, they put in place a commission, for COVID-19. And one of the critical functions of that commission is workforce development, and is key to what we are doing here today. And I'm glad that 2 of the 3 people who are actually driving that work stream are part of the discussion today. That's Gitinji and Professor Maha. Then, if apart from trying to advocate at the highest political level, another thing African Union can do is to use our convening power, bring together all the relevant stakeholders. I agree that for now, what is obtainable in most of our countries is that the training is done by the Ministry of Education, but the practice is supervised by the Ministry of Health. And these are 2 sectors that do not really talk together very much. And when it comes to salary, that is also done by another ministry, labor and productivity. So as Africa CDC, what we intend doing going forward is to use our convening power, bring these sectors together, have that robust discussion. If you look at field epidemiology training program, it's already happening. Field epidemiology training program today, 30% of what is done is within the Ministry of Education. 70% is with the Ministry of Health. So if field epidemiology training program can get it right, that means other places like data science, training of epidemiology can actually get it right. So we use our convening power to bring all these sectors together so that we understand that the way we used to do things in the past need to change. If at all we are going to have a fit for purpose health workforce going forward. Another thing that is also for us as Africa CDC, we have a framework for workforce development, and that is due for revision based on what we've seen from the COVID-19 pandemic. And with that, we'll be able to support member states, especially when it comes to standard, when it comes to curriculum, when it comes to issues of accreditation. We talk of mobility. Kenya said it's not producing health workers just for Kenya. They want to export them, But how do you export when we have varying standard across 55 member states? So what Africa CDC can do, or is doing, standardize that. Put in place accreditation mechanism so that if I'm trained in Nigeria, I can go and work in South Africa. If I'm trained in Lesotho, I can go and work in Zambia. So Africa CDC will continue to support that particular agenda to make sure that that mobility is there. Then we also need to find a way, or Africa CDC will continue to work with you to have in place what we call a National Public Health Institute or National CDC equivalent. So we believe that with that in place, we should be able to have a body that will be able to coordinate at the national level. And we have seen that for most member states, with those national public health institutions, they have been able to address some of this workforce challenge. I know that in South Sudan, we have the national public health institutions there. We have EPHI, we have the CDC in Kenya. So all these institutions actually have a role to play. And Africa CDC will continue, to support each and every member state to have such institution in place. I know we are pressed for time. Our head of state and government have called for the need for a new public health order. And we want to rally each and every member state to support that. When my acting director was speaking at the WHO, the African region meeting, he did emphasize the importance of that and what we intend to gain from that. And critical to that is the workforce development agenda. In fact, it's actually pillar 2 in there. So we believe that if we get that right, if we all support that new public health order that seeks to strengthen our health institutions, workforce development, build local manufacturing capacity, respected and action-oriented partnership, domestic financing of all are actually underpinned by critical workforce. Because if you don't have adequate workforce, there's no way you can build your local manufacturing capacity. There's no way you can talk of health institutions. There's even no way we can guarantee the health security of 1.3 billion people, 55 member states. So I think going forward, we want to see this new public health order being the way of doing things, and we see it as a way to get to that fit for purpose workforce that will be able to help us come out of the current pandemic and respond better to any subsequent pandemic in the near future. So thank you, Gitinji. Over back to you.
Thank you very much. A big hand for Dr. Now, as we conclude, I want to remind all country representatives that there's still time to support or to co-sponsor the health workforce resolution that has been introduced by Ethiopia. And I know the Minister of Ethiopia is leaving because they're meeting at 10. So I'm calling out the country delegates to support and co-sponsor that resolution. So we have meetings at 10, so we need to conclude. But before we conclude, I have 2 one-minute remarks. The first one is Dr. Letlape. 1 minute, he would like to respond. And then I'm going to ask, and I'm honored to have the chair of the Parliamentary Health Committee in Kenya, because the legislative agenda or the legislative arm of government is extremely important in ensuring that we achieve this agenda. So I'm going to ask Honorable Sabina to make 1 minute remark, but please, let her pay 1 minute.
This might be a long minute, but I'll try and make it a short minute. One, health professional training should be under the Ministry of Health with input from education, not the other way around. Otherwise, it doesn't work. We've got to demand human resource plans from each country. And I'm glad I had the minister from Ghana speak about those issues. There has to be staffing norms. And we've got to train in accordance with those plans so that we don't produce people we don't need. And that's important. There has to be a common accreditation in terms of a curriculum, common assessment, and common accreditation. If we can do that in Africa, then you'll have a mobile workforce that is fit to work anywhere. But there has to be professionalization. If we are going to have team-based care, it must be based on professionalism. I'm the son of a nurse, and my mom used to do what is now being delegated to community health workers. They used to deliver babies, they used to go into the homes, they used to teach mothers how to breastfeed, but it was done with professionalism. If there's a plan for people, lastly, as Africans, we're not lesser human beings. We can't come up with all these studies and try to retrofit them. And what we create must be used by those of us at the top. Community health workers can't work for the rural community. They must work for the house, the state house as well. We have to take our place amongst humanity as equals. But we've got to treat our citizens as full-fledged human beings as equals. And lastly, my vice president of the Health Professions Council used to say, never congratulate a fish for swimming. If you're a regulator, do your job. Don't expect to be congratulated. If you're a government, govern. Don't expect to be congratulated for doing your job or get out.
Thank you very much. Thank you. I want to reassure you, Dr. Letlape, that almost 70% of the care and oversight for my mother's hypertension is done by a local community health worker. And then whenever she needs care, then there's a referral process. So it's actually all the way up and down. Now, Honorable Sabina, do you have a mic? You could just make a 1-minute remark. And at the same time, I want to give a shout out to Vanessa Carey, who is leading the Seed Global Health, who is joining us, I think, virtually. Yes, Vanessa Carey, thank you for the support. Yes, Sabina.
Thank you.
1 minute. I know you're a politician, so 1 minute is really difficult to manage. But let's try and manage 1 minute.
Thank you. I'm actually going to be less than a minute. Good morning, everyone. Mine is just to thank all of you for being in this panel, and of course, your contribution. As a lawmaker in Kenya, we work closely with the Ministry of Health, and we are always willing to make laws that are able to support what we are doing. And I can say I was part of the team that was in Mombasa in Kenya, and we are working together to ensure that our health workers are well taken care of. And I want to support the sentiment. Formerly, I'm a second-time member of Parliament, and initially I was a chair of Education Committee. I want to support that. We need the training of health workers to be taken care of by the Ministry of Health. Yeah. And of course, then the Ministry of Education can support. We initiated a hospital in Kenya, which is a Kenyatta Referral Hospital. And of course, when it was under the Ministry of Education, the hospital couldn't work because they didn't know what to do with the facility. And once we handed it over to the Ministry of Health, then we were able now to start the hospital, which is also going to be a training center and the best training center in Kenya. So I just want to congratulate all of you. And I hope as we go back to our countries, we're able to implement majority of the things that we have spoken here. And we as the lawmakers from Kenya, I'm also with my colleague, Dr. Murgo, we are willing to continue supporting our health workers in Kenya because for sure, a healthy nation is a wealthy nation. Thank you and have a wonderful day.
Thank you. Thank you very, very, very much. To our panelists, please, a big hand. It's been a big conversation, and thank you. And to you all joining us here in person and virtually, as we close, we realize that health workforce development is going to be a joint partnership with everybody. Amref Health Africa is announcing that we are going to have a scholarship fund for nurses and midwives we are going to focus on women. And specifically, we are going to focus first on the countries that are most left behind. So we are going to be working closely with the countries and Africa CDC to identify where the biggest gaps are, especially in those countries that may be fragile states that have a very low workforce capacity. We are going to focus on women, and we are also going to focus on diversity, inclusion, and equity within that scholarship. And we are announcing a multi-year scholarship for those through Amref International University of $500,000. We are going to be working with the countries to ensure that we can deliver, we can identify those nurses and identify the areas of training that we need for each country. So thank you very much. Remember to carry the flash disk that you have on your table. Thank you for attending online. Thank you for being here in person. We've run out of time because this was a really critical conversation, and I know it's also going to be a critical conversation through the week with the within the World Health Assembly. Thank you very much, and enjoy the rest of the week. Thank you. If you don't mind. And
thank you.
So Dr. Ahmed, please come up. Jim, could you join us for the photo? Sabina, join us for the photo. And Dr. Veronica, please come up for the photo. Thank you, Dolores, for joining us virtually. And you can probably stay at the back for the photo on the screen. Photo here.
All right, thank you.
We are in the photo, we hope.
I think we are.
We know those before.